Yes, hi. I am Shaher Khan, Dr. Khan from Plastic Surgery. I have Tracy here with me and my former patient here. I won't mention her name, and another patient to be with us who's going to join us. She has good insight and experience of an operating room at a major hospital here, and so she's going to talk to us about her experience. What I'm here for is essentially Tracy. She's a big voice, not only here in Michigan, but actually nationally and internationally. She's here to advocate for the patients who have implants and patients who want to get implants, who our job is to educate so that they are very good informed patients so that they know what they're signing up for. And also we want to go ahead and shed some more light. So essentially this is going to be a question answer session, and I'm going to have my patients to kind of jump in and at least share their experience so that we can better the system and so that we can offer the best quality of care to our patients. So please go ahead and Tracy, ask me any questions.
Okay, so we have a Facebook support page, and on it, a big debate amongst the women is, do I do drains or don't I do drains? And a lot of the posts are, I'm not going to a doctor because he puts drains in, or I'm not going to a doctor because he won't put drains in. And so I was hoping you could clarify, like, I used to be all pro lift, and now after hearing from you and other doctors, I can see why doctors don't feel comfortable doing lifts at the same time as end blocks. So I get it. So I'm hoping you can explain the drain.
Sure.
and all the pros and cons of drains.
Sure. So drains are an important tool for us so that once we have done this dissection, which is the end block dissection, where you're essentially removing the implant plus the capsule off of the chest wall and off of the pectoralis on the top, we have a lot of fluid that eventually builds up because of the nature of the dissection. Now, if the technique is done right, where you have a very nice, smooth, and like in a painting type of a format dissection, very meticulously and nicely done in the avascular plane, the tissue that's traumatized is minimal, and so the bleed or the serous sanguineous discharge or the ooze that occurs as a result is much less than compared to, let's say, someone who does it technically very deficiently or incorrectly. Now you have tears in the chest wall that might ooze, or in the capsule that might potentially ooze a little bit because you have gone into the capsule. Then you want to have drains so that they will collect that fluid. To have drains is not going to prevent a hematoma. If you're going to collect a pool of blood inside the chest, the drain is not going to prevent it. If anything, it might alert you, but the blood gets coagulated, it forms a clot just like jello, if you will. It cannot drain out of the drain. So the drains help with the fluid. Now, from my plastic surgery experience and as a board certified plastic surgeon, if I do an abdominoplasty, it's such a vast area from the xiphoid all the way down to the area of the pubic symphysis. It's a huge area. I not only put in one drain, but actually two drains because it's a huge area of the body, and I want to collect that fluid, and I don't want it to build up because it can form a seroma, which is a collection of fluid. This is the fluid that builds up when you donate blood. The red blood cells settle down, and then you have the plasma. We don't want that to build up. If the dissection, so 100% of the time when I do an abdominoplasty, I put in drains because that's the absolute standard of care, and I question the doc who does not put them in. Now, conversely, on the breast, when you do the end block removal, if you do it very nicely and meticulously, as I want you to see on my YouTube channel, very carefully, you're handling the tissues like you're handling a piece of egg. You don't want to break into the capsule. Very important. You will notice even in the videos I mentioned that the dissection is very good. I feel comfortable. I gently pick up, usually with my fingers, because this is the softest area and I feel exactly how much I need to pull and push, and it's a constant drive. I have not had the need in 95% or 99% of the patients to put in a drain. Now, if I ever am sitting on the fence, do I or do I not? I always put a drain in. Why? Because I can always remove it 2 days later. Now, God forbid, if I need or there is a collection of fluid that forms, I can always aspirate it, put a needle in after sterilely dyeing it and removing the fluid and sending it off to pathology, because this fluid should not have accumulated, because the body in itself absorbs that fluid. Less than 30 cc's, as we all know from our surgical experience, the body itself will absorb. Now, if I pull out with the capsule, 700 cc implant plus the capsule, that's double the area. That is going to produce more fluid. So in that patient, I will put in the drain because I want to be safe. I don't want it to form a pocket where the fluid builds up, and essentially it's a potential for infection. To have drains in is a dangerous, now if you need it, you need it because you don't want that fluid to build up. But to put it in for, like I heard a patient just today come in and say that my friend had drains for 2 weeks. That's dangerous because the drain itself induces fluid. Number two, let's say if you're sleeping and you twist and turn and the bulb suction goes off, that fluid can backtrack. Or if you try to remove it and then you insert it back, you essentially reintroduce the bacteria into a nice, healthy, sterile pocket. And I just heard for the first time in my career that the husbands are removing the drains. I would call this very boldly and very safely malpractice. This is not safe. This should not be done. Removing a drain is a procedure which should only be done by an MD, period, not even by a nurse practitioner or a physician assistant, because it needs to be done very tactfully. If there's a clot, you have to examine, you have to feel the need that the drain needs to come out. If it was put in, why was it put in? You never go in around the axilla because that's where the lymphatic channels are. They can drain into, and that's why when people and women have mastectomy and sentinel lymph node dissection, almost always inevitably we put in a drain because of the nature of the dissection that goes. Now I have one of my patients here with me, and she actually has worked in the operating room. She's going to shed her insight into her experience as far as what she strongly feels. And I just met her yesterday, almost 24 hours ago, and I said, you know what, please come in and share your experience because yes, you're not an MD, but I'll tell you have good insight and knowledge to know as to when the drains need to go in and why not.
Yeah, I did. With my visit with Dr. Khan yesterday, that was one thing that I brought up to him because I've seen a lot on the Facebook group, as Tracy was saying, is that women, one of their biggest fears is what, probably number one is what they're gonna look like after their explant, which I think is completely normal to feel that way.
Exactly, because it's what led us down this
Right.
path anyway.
It's normal. We want to know what we're
And
going to look
vanity.
like. We have
Yes.
fears, but I think the second most fear is not only that they're, going to have some trauma to that area and be put under general anesthesia, that they're fearing the drains, and they're not scary, like Dr. Khan said. They're there for a reason. They're typically not something that is predetermined, other than the other surgeries that he mentioned. He knows that this is going to be necessary, but it's not usually predetermined that the doctor's going to say, hey, I know I'm going to put in 2 drains, this is what you're going to have. And we're finding on the Facebook group that women are questioning other women, saying you didn't have drains, why not? Or my doctor said I'm not going to have drains, and telling them to run and go find another doctor. That's not the case. This is only a place for medical necessity. You should not be scared of them. They don't hurt. They're more of a nuisance. They're little extra friends that you might have. But the risk of infection is the reason they're not just inserted just because, which is up to the doctor and the surgeon to determine how they're going to weigh out those risk factors of, is it more important to put these drains, or is it we're going to take the chance of having these drains in and weigh those risk factors of infection. So I think that's something that they need to know, that if you do not have drains, that does not mean that your surgeon did not perform the surgery correctly or incorrectly. So I think Dr. Khan pretty much summed it up on why and when they should be used.
The other question, if we're done with that,
Yes.
are we done
I
with
think
that,
we're done with
ladies?
that.
I think so.
Okay.
Yes. So the other question you asked was in regards to the lift. Now I will
Yes.
tell you this
That's what I
is
want.
very important. What I did was just within the last 2 or 3 weeks, I have done the explants, and I told the patients, each and every single patient that comes to me is concerned, how am I going to look afterwards, which is a very reasonable and logical question. I have a patient here who I just met, post-op now 23 days out. Please talk about your experience, how you feel overall, and then how you feel about the lift.
Who, by the way, I know her friend. I'm going to lunch with a
Yeah.
gal that she knows
Small world, very small world.
today. Yeah.
I did not get a lift, and same thing. on my consultation, I said, I figured I would need one. I said, so what do you, and he said, looking at you, I don't think you need one. I said, okay, I trust your judgment, plus it's more money, so let's just go with what you think I need. And I am so happy I did not get one. I didn't, he took pictures today, I did not need it.
Yeah.
So,
That's where I'm coming around to that way of thinking.
yeah, I mean, it's not always an instant, yes, I need a lift.
So my take on this is this. You have an implant that's causing a disturbance, swelling. You can see the engorged veins. You have inflammation around the capsule and around the native tissue. Take the implant, the capsule out, let the burden leave. Let this settle. There is a recoil. Recoil on a,
Yeah.
let it heal. The 26-year-old is going to recoil much better
Yeah.
versus the 82-year-old lady that I took care of. A person who smokes, and I always tell my patients we have to put the best foot forward. It's not an emergency that we have to, so I tell the patients at least 2 weeks, preferably 6 weeks you stop, because we don't want any necrosis of the flaps. Remember, it says causes heart attacks because the carbon monoxide, amongst the many other chemicals within the smoke, causes the vasoconstriction. The same thing that we don't want, the same vasoconstriction that causes the heart attacks to affect the flaps. And so we want this recoil to happen. We don't want to go around the nipple causing scarring. This is a lot of extensive scarring. We don't want to do any of that. Let the burden be removed. Now, most of the times you won't need a lift. And almost always the patients are surprised, wow, you were so right. Now, I cannot guarantee if you're not, or you will, or how and what the skin genetics, sun damage, alcohol, believe it or not, consumption affects the skin elasticity. And so a lot of variables come into play. If you're premenopausal, postmenopausal, so all of that factors come into play. And so I say to the patients, sit tight. That's stage number 2, if at all. And hopefully you would not need it. You do not want to compromise the sensation around the nipple or the areola. Look at the pictures, that big removal of the implant, and now you're going to go in and do more surgery. You're already almost 3.5, 4 hours into the surgery. You're going to add 2 or 3 more, increases the risks for DVT, and let alone
What's
if you
DVT?
deep vein thrombus, which is clots in the legs.
Gotcha.
Because the longer you're on the operating room table, the higher the chance of infection statistically. After 6 hours, it's been shown that you should wrap up the surgery in order to play it very safe.
I was a high risk for blood clots too, and
Yes.
that was him wanting to even take me on was huge because I, in 2018, almost died of a massive DVT from my heart to my ankle and in both lungs. So I'm on Eliquis for life. So most surgeons would be really scared, and he thought about it for a long time and how he wants to approach this, and actually had me stop my Eliquis, I think 2 days before.
Yes.
And I bridged to the Lovenox injections, and everything went great, but it was scary.
And you were set up for a hematoma. You were set up for badness, which is a collection of blood, and very tactfully, very meticulously, you did not even need drains because
No.
I felt comfortable. And remember, I said, I normally don't, but if I think about
Right.
it, I will. So don't feel bad. But I tell you, the surgery went very well, and I felt very good, despite you being on therapeutic levels of Lovenox that will cause you to bleed internally, because this is a pool waiting to happen because of the nature of the dissection off of the chest wall.
And how long ago did you explant?
23 days ago.
23
Yeah.
days.
If I may mention, I just heard, tell me what was your activity 2 days ago?
Yes, 2 days ago, which was what, Tuesday? I walked 3.5 miles and actually jogged a little bit, but I'm like, maybe need to stop that. And then yesterday I went kayaking.
Oh.
And I went in a 2-seater thinking my son was gonna do all the work, and I ended up being.
Were you actually?
Yes, and I
Wow.
had no pain, 0 pain. I felt great being
That's
outside.
not too soon?
You know what
Is
I
that too
told?
soon?
He
I
said
think that's too soon.
No, he said, listen to your body. And I told my son, if it hurts, you're gonna do all the work. And I didn't feel anything. Nope.
So is it more of a pain thing?
So it's a
where
pain. The
you don't
pain-
want her to have pain, or can it do more damage, so you don't want them to use
So
activity because it
the
could cause more
body is
damage?
very smart. Body knows, you know.
Yep.
Had you been a teenager, I would probably have you in a vest for like 4 weeks. But I trust you,
Yeah.
and you trust yourself.
Right, oh
You
yes.
have the wisdom, and I can rely on you saying, you know, if it hurts, don't do it, because the
Right.
body will tell you
Totally,
that I'm
yeah.
hurting, give me some more time. I have had a
Mhm.
patient, 3 days post-explantation, she went camping. And this was below the muscle.
Wow.
As you saw, one patient on TV, channel 4, 2 days later was on TV, but hers were above the muscle. Very different
very
situation.
different.
And she was, I will tell you, a very powerful lady, meaning she's a determined lady, and but she felt comfortable.
Wow.
And this is when I had asked you to come, and the other lady, she stepped up because I just talked to her. And I said, you're driving already? Can you drive to channel 4?
I can't believe she was driving already.
Yeah. But
Right.
you know what, I'll tell you this.
Although I had the lift and stuff, so.
Right,
Yeah,
right.
yeah, yeah. So now what I'm gonna do is I actually this is my set of patients for the last 3 or 2 weeks. Over here, this is before the explant. This is on call on the way to the operating room. You can see her
Mhm.
here. You know, that's covered by that device, and now you're gonna see this is her before. This is in the operating room. This is, I have the initials and I have the date so that you know. This is her after the surgery. This is exactly 1 week after, 168 hours after the surgery.
Wow,
She
looks
did
great.
not, can you see the incision? And if you
No,
could please
it's in
dim the
phone.
lights there.
How
And
do
you
you
can
do-
see, if you could just press the bottom one, yep, yep. And you can see right here, she did not need that, so I'm gonna go back into
Right.
the same. This is her on call on the way to the operating room. This is her on the way to the operating room, the left side, and you can see this is her here, that's covered. And so this is that small box that you see, this is in the operating room. This is removal and block, as you can see, I've already removed the capsule on that one. And this is after.
That's after, oh my
1
gosh.
week after. And 1 week after, you can see this is the same patient, exactly 1 week after. No need for a lift. If you do a lift on this patient, you've done her a lot of disservice. Now, this
Yeah.
is one patient of 3. Now, what I'm gonna do is, the patients asked and said, can you post more pictures? I'm gonna actually show some more, please. So this is a second patient, and you know, hopefully these ladies will post as well on their own. Now, this one lady, I actually did not post her pre-op picture, but as you can see, this is exactly 1 week post-op. Does she need a lift?
No.
Remember, she is
Mm-mm.
37, she's gonna recoil on her own. Does she need a lift? Absolutely not. She does not. And look at her native tissue, and she was very much surprised. Look at the placement of the nipple areola complex. It is exactly where you would want it on a 37-year-old. And so this is this is my second patient, and now I'm gonna show you a third patient. And these, hopefully the patients will post themselves on their own as well. And this is another very interesting case. Very nice lady. She came to me, and I'll use exact dates. On the 31st. What do you see, Tracy, over
Oh,
here?
yeah, the rash.
The rash.
Mhm.
On the 23rd of July, 2019, she saw me as a consultation on a Wednesday for the first time. She came to me, she had already been to an infectious disease doc who referred me, a close friend of mine, dermatologist had put a rash cream on. This is exactly where the implants are sitting. And she says to me, I think it's the implants. You know what I told her? It is the implants.
How long did she have the implants in?
10 years.
Okay, so
Exactly
this
10
is,
years.
it took
How
about
long
10
did she have
years
the
before
rash?
she started.
The rash was there for 5 weeks, 6 weeks. So she had bounced between her endocrinologist, her PCP,
But
her
see,
infectious
I didn't
disease
have any of
doctor, and then now she's unusual. And see, every patient presents in a very interesting,
Yeah.
mysterious way. They have their
See how
complaints.
long it takes though for some of these symptoms to show up, where
Right.
some are weeks after, some are months,
Right.
some are 5, but I'm finding that a lot of them is the
Years.
8 to 10 year
Mhm.
mark or more when you're supposed to have them removed, and when we don't see, you know, a physical change, we don't do nothing about it, so we don't know they should come out. So then we
Mhm.
start having all of these symptoms, our body goes into havoc.
You know, what you mentioned is very important. The average span on the chest of an implant is 10 years.
Mm-hmm.
So plus minus depending on the patient, the implant, how they react. So as you can see, she's referred to me by the dermatologist and infectious disease doc. Something is wrong with, now she is got multiple medical other issues going on. She's not a candidate for oral steroids too. So the next thing you know, she comes to me and you can see the rash, which is very dramatic, right over exactly where the implants are sitting. And this is pre-op. This is 7/31/2019 on the 31st of July in my other office. I take her for surgery. You know, and this is the rash again. I take her for surgery now, right off of the chest wall, as you can see. This is the rib. This is the nice, healthy, viable muscle. No capsule left behind. This is right again, very tedious, meticulous dissection. I have to say these two retractors are the best. They curve in and you lift up and you need to go and see around exactly so they give the best access. And then, as you will see here, removed end block. These are the, and look us where she is.
Wow.
Was it right after?
This is exactly 1 week after.
There's no rash?
Yeah, so guess what, on the 7/31, yeah, no rash. So 7/31, I saw her for the first time. On that Monday, which is on the, 6:48 in the morning, she told me that the rash is spreading. I gave, because it can cause septicemia, because that rash can become folliculitis and an infection. So I told her, on Monday she called me. So Wednesday I saw her. Monday I told her I'm gonna go ahead and cancel my Wednesday surgery. 2 days later I needed to get a cardiac clearance because she has a major illness and I don't want any surprises on the OR table. 48 hours from the time she called me that the rash was spreading to the rest of the body, because I don't want her to get fevers, septicemia, she can have an infection going around. And the next thing you know, I do her surgery on that Wednesday, exactly a week after I had seen her. And then this is exactly 1 week after. So on a Wednesday again. So this is 2 weeks from her initial presentation and a week after her surgery. Does she need a lift? Do you see the scars? And she's gonna be actually talking and posting about her pictures. And actually I have one of my other team marketing people actually documenting her memoir as to what and how she went through. And as you can see, the scar hides very nicely. She does not need a lift. She's 52. So the point is, to answer your question, the goal of the operation, you can turn the lights back on please. The goal of the operation is get rid of the badness, the implant and the capsule, let the skin recoil. As you can see in these, each one of the ladies was surprised as to, despite the implant removal, they didn't have the sagginess. Now in the OR, I will tell you, it's very meticulous dissection. Sometimes I may have to do a quilting suture here that pushes the tissue out, because now what the quilting suture does is it prevents the fluid from buildup, because now there is a tamponade. Just like with the abdominoplasty, you anchor the skin down in so it doesn't shake around. Every patient is different. If I have to repair the muscle, the pectoralis, I anchor it down so that when the patient starts working out, just like you did with the kayaking, go get some 5-pound weights, get some muscle back in.
Yes.
So because that's gonna build that muscle just like the bodybuilders do it. Get rid of the insult. You might not need a lift. Lift is a involved operation. Around the nipple, going all the way down with the anchor incision.
Yes, I can show you.
Not warranted on the day where the goal of the operation is,
To get 'em
just
out.
like a Navy SEAL, I just use that term. Go in, take care of business, come right out of Dodge, let the skin settle, revisit it a year out if you need to, and hopefully you will not need it.
Right, yeah, and we do have a gal, on the page who went to a doctor and got a lift and the nipples are too high.
Do you know why? Because the
They-
skin
they're too high.
recoiled.
Yeah, so exactly what he's saying.
Wait.
So, yes.
Let
it
I-
settle.
I
Let it
can't
settle.
say do a lift, don't do a lift, that's up to you.
Every patient
But
is different.
I'm just saying, there are risks.
That goes with me saying the fear of what we look like after. So they want the lift because they want to
Right.
see the full picture right after.
And you see the women who have the beautiful results,
Yeah.
and then you see these poor women that also go get one and they don't have beautiful results.
Right, yeah. Well, their lips might look good following, a week following, 2 weeks following, but like you said, when the skin and everything starts to recoil, things shift and they change.
Yeah.
And might not be as, it's not meeting your expectation.
Every patient recoils differently. Like I was saying, the genetics, their history, their sun damage over the years when they were in their teens, remember, because it all adds up. So we have to factor that. And right now, keep it very simple. Don't make it a very complicated. Just to do a lift alone is a very involved operation because it comes with its own set of problems. In sensation ear loss, necrosis of the nipple, malpositioning of the nipple, which is a very difficult problem to fix. Now, I'm going to say another thing that's very important that I find that the ladies, there has to be a check and balance for me, for my other colleagues, whoever it may be, because this field from a plastic surgery perspective is not well defined. So what are the tools, modalities, techniques that you need to know, to learn, so that you know that your surgery was right? Because if you ask me, from what I know now, in August of 2019, one of the biggest problems is where you have had the explant and part of the capsule remains behind, and we know from the pathology that the capsules have looked at, like I was showing you, there is silica in the capsules, because this has been proven pathologically, i.e. with the pathologist looking at the microscope. You want to make sure that the start and close time is 3.5, 4 hours. You cannot do 6 of these in a day, no matter how fast you are, unless you start at 7:30 and finish at 1 in the morning, Number 2, you have to make sure that the incision is 11, 10, 11, 12 centimeters, depending on the size of the implant, because if it came out through 2 centimeters, you cannot do end block around the nipple only, like you've mentioned yourself. So the size of the incision needs to be, the best incision is at the lower part, as you can see in these ladies, and as you will attest, it hides very nicely. No one sees these. Number 3, you need to make sure that you get the pictures, because each and every single picture here has a footprint. It tells you the time, date. If you turn the GPS on a phone like this, you will be able to pinpoint, exactly where the HD cell phone or one of the high definition cameras these days tells you exactly the imprint because of the time. Number 4, you want to be able to see, if you see bruising, I tell the patients you need to go hug your doc, because he did the right dissection. It is a very tedious dissection off of the chest wall. If you're hurting after the surgery, you got the right surgery. Unless you had the implants above the pectoralis, because now the muscle was not disturbed, it's only a skin thing. So that's why you can be on TV 2-3 days later, because that's a very different surgery. And number 5, we have the explant experts across the country. They have a reputation, they have a passion. They're not putting in implants. They believe in breast implant illness wholeheartedly. They're determined, motivated, fixated, and the goal of the operation is well defined. They're like, what do they say? 1 free soldier is better than 10 hired ones. You pay someone to fight for you, they'll never fight, versus if you fight for your own, from your heart. And that's why I say to you, you're going to get the surgery that you deserve, so that come next year when you get your mammogram or your ultrasound or your MRI, they're not going to say, what is the silica foreign body floating around? Because this is what the other ladies find out, which 90% of the capsule was removed, but guess what, the 10% remains, and then that 10% is the silica that you and I were talking about that we know. So I find this is all very important to kind of keep in mind, and ask questions. I have to say, there are a lot of Facebooks. I've had a chance to talk to Nicole DeRuda now twice extensively. I called her just 2 days ago. It was 5:30 in British Columbia, and I was driving here. I didn't realize she was in that part of the Pacific Coast. She and I talked, and I gave her good insight. She gave me good insight, and she's done a lot of good, as genuine as a person can get, who's made an impact, I would say, in millions and millions of people. You have almost 90,000 or so. Tracy doing for Michigan, and what she did with the FDA, hopefully we can all get together and we can better the experience of the patients and learn from each other, so that, if I can better the technique, I am very much open for someone to call and say, I want to see, or I question this, and you know, Tracy called and said, you know what, I said, I will tell you what I know, maybe I can learn from this.
Yes. He listens, that's what I like about you. He's on our side.
Mm-hmm.
Any other questions if you have Tracy?
What else did we have? You had a whole list yesterday.
I did, and I think
Did
we
we cover
went
it?
over every single question that I had, and he answered
I do have one from the
most of
boards.
them.
One when I was looking last night after talking to you, I went back and looked at all and there was discussion about you leaving capsule behind, so I figure I'll get you on video right now,
Sure,
clearing the air for them, because I did respond. Your response was you didn't do it, whatever. Can you just tell them?
So for me, I have a lot of information that is put on my website. It's like a big enterprise. There's information being put, my marketing people are putting information, they text me, email me. I don't have time to, between clinical care, operating, taking care of patients, I'm probably working 80 hours a week easy, if not more. Between the charts, finalizing the operating, I get information that's put on my websites that is essentially done in a marketing format. Even today I was showing you, my marketing person, is it okay? I don't have time to read pages and pages of information. Something does get slipped, I will tell you, I've gone around and I go around practicing not only to my patients, but to my attendings, my friends, my other plastic surgery colleagues. You have to remove the capsule. You cannot rupture the implant, absolutely forbidden. That's a major sin. You cannot leak that fluid, the saline, into the chest wall, because that is a major sin. That's why I say to you, I want to see the saline implant removed so that I give it to all my patients and I say, this is your property, this is for you, this is proof for you to see that the saline was not ruptured. And I will tell you, in today's world and age, I know well over 90% of the docs who remove implants unfortunately rupture because they want to go into a 2-centimeter incision because they want the cosmesis. No one's going to see that scar. Remember, the goal of the operation is one,
Save lives.
save lives, to remove. This is the punchline, this is the take home message for everyone. You have to remove the implant and the capsule as one system. You don't want spillage of the internal contents. If you look at the saline implant and the day it was placed and you weigh it weighs X grams. The same implant you remove 10 years out or 15 years out weighs more.
Really?
Yeah, they don't know why.
So you're well read. Now I will tell you that implant saline
Isn't
that
that crazy?
weighs
Yeah,
more.
an example would be it weighed 10 ounces when you put it in, and now it's like a pound or something when they
Right,
take it
now
out.
by a small amount, because there
You
is.
posted something that was ridiculous. Was
So
it this
the-
morning
the-
about the guy hammering the implant?
Oh, yeah.
Yeah.
It was hard.
Yeah, so the point I'm trying to make here is you don't want spillage of that saline which weighs more, because I'll tell you, see, I'm a biochemist in undergrad training. Take that fluid and I tell the manufacturers, I tell the biochemists, I tell all the mass spectroscopy people, which basically means that you take that fluid and you do analysis just like you do on tap water, and they can tell you how much chlorine it is, how much metallic, how much antibiotics and whatnot else. You can pinpoint and say, this is how much silica, how much what, and you know what, that will be a very nice PhD project for someone, you know, where, you know, many companies and firms, I'm sure they would be very much interested in knowing, what is this fluid? Why does it weigh more?
And what scares me is I told them my implants are empty now. I had magic markered on them. I evicted the girls, and now, and it took maybe 6 months, and within 6 months of explant, they're empty. And they
What
have
made
just
them evaporate?
crystals, salt crystals are in them.
See, they're porous. That's the whole problem.
So
They
when
are
they're
porous.
exposed to air,
Yeah, I do not know, and since this is where the research needs to happen. And if you can imagine, you know, we learned this in grade 3, if you have a membrane and osmosis and diffusion, you have normal saline, which is the same salt water, 290 millimoles of, you know, the solute. If you are, the water there will be traffic back and forth. And so this is where your potentially high grade silicone, I do not know, but this is where the research needs to be.
So, when I had my rupture in 2010, they were saline, they were textured saline, McGann, and woke up to a flat side, So all that saline solution went
Oh.
through my system,
Right.
and I couldn't get in for over a month because I had to make an appointment with Postop. I had to make an appointment, I had to get a mammogram and get it all lined up.
Did
And
anything
so-
cause the rupture, or you just woke up like that?
Well, now I'm wondering, after the hard capsule and stuff, I think the mammograms are causing the ruptures.
Wow.
I think mammograms are causing ruptures, because if I've got that hard capsule around it and you're squeezing it, how did I get a rupture to come through the capsule?
See, what happens is if you look at
How did
the-
that?
Yeah, so any pressure, they tell you no pressure, you know? And over time, remember, this is a product. It will burst just like any capsule would. And so just a little bit of a pressure, if it was below the muscle, when you're twisting and turning at night and you press, it's gonna rupture. And just like everything disintegrates over time. You know, they're not meant to be forever. And this is exactly what happens with saline implants. When they
That's
rupture, it's like a flat tire, you know? You have a flat chest.
You can't remove that
Yeah.
fluid.
And
your
that-
body
and
just
Because
has
it's
to
absorbed
absorb
over,
it.
and this
Yeah.
is the same absorption of the fluid that occurs when you don't have the drain, because the body itself accommodates and accepts that fluid readily.
I sat there and wondered for the whole month, like, I didn't wonder then, I do now, like that whole month of waiting to get surgery. What was that implant doing? Sucking in blood fluids, pushing out fluids, sucking them in, pushing them out. What did it look like when he pulled it out? And what was in my system from it? And did it have mold? What if it had mold or something? What if it was contaminated and it went all through my body?
See, this is why whenever I have done the surgeries, just like in your case, I have always, even if it looks normal, there's no abscess, nothing, I always 100% of the time tell the patients, get the aerobic, anaerobic, and fungal cultures, because you never know what could be inside. When I've closed you, it might be too late, because if there's a growth, we want to be able to deal with the antibiotics accordingly. And so that's why, so one ruptured implant that I removed, in it was heavy, thick, viscous, honey type consistency fluid. And I showed this at the June 18th seminar that I had. I sent that off to cytology because you have to rule out the ELCL.
And what was it? Was
It was benign.
negative?
Yeah, negative.
Oh.
Because they have to send it to cytology, and you have to write out as a board certified plastic surgeon why. Because you have to let them know what you're thinking. Because they might just do like a regular analysis on it. No, you have to rule out breast implant capsule fluid abnormal, rule out via ALCL, and obviously talk to them, because if they don't see this, the mind, you know, the eyes don't see what the mind doesn't know.
Now, why is it important that us women get our implants back? Or why, well, we know why it's important, why we get them back. Why are some doctors not giving them back to their patients and
So-
saying we don't give the implants back?
So I will tell you, the implants, what is going to happen to the implants? They're going to go into biologic waste. No one's going to look at them. I say to the patients, that's proof for you that the saline implant was not ruptured. Other than that, now if you take it home, no, the other reason why I see, and what the patients have themselves told me, it's going to be a part of like a massive recall lawsuit / studies. The moment it goes into your home and you've looked at it, it becomes, God knows, altered, because, you know, and again, I do not know.
Right.
Like one patient took the implants, she told me herself, and she put them in the basement. And 6-week mark, she came and she said there's mold growing. No, I told her, this is, if you put a loaf downstairs right next to the implant,
it's damp.
yeah, it's
Yeah,
damp.
there's
And
all
so
kinds of
you cannot
factors.
say, and that's a valid question. But I told her, listen, fungal cultures are negative. Fungal cultures are negative, so I want you to rest easy, because this was not in you with the mold. And look, I put that saline implant and I held it against, you know, like the writing that I have, and I can see it's transparent. And it doesn't take much to realize if there's a problem. So that's why it's important for you to ask, and this is in your pre-op. I always tell the patients the implants you get, the capsules go 100% of the time to the pathologist so they can look at it, make sure there is no malignancy. Number 3, I send cultures for micro, aerobic, anaerobic, and fungal, and if any abnormal fluid, I send to cytology. So this is my like rubber stamp, because that way I don't want to miss anything.
Is Is this a red flag though to women when they go consult
Yes.
with someone and they say, we don't return them and we don't take pictures?
So I will tell you, I
That's
will.
a red flag for me.
And a lot of
Yeah, for
postings
me too,
lately.
but it is though, coming from you, do you think that that's something that should be a warning?
I will
Why,
tell you
why don't
in-
they wanna give them back?
Right, what's the
So-
reasoning?
so I
We
will
should
tell
be
you-
scared?
I will tell you, there should be complete 100% utter transparency between the surgeon, and the surgeon runs the show, not the nurse practitioner or the, it comes top down. Like my practice, I assume 100% responsibility. Oh, anesthesia is responsible. No, I'm responsible for the anesthesia. You have to go in and I ask the patients this. Number one, 5 things. You want the implants back. You want the pictures, 100%. There is a fingerprint on each picture when it was taken, and this is what I was just talking about. Number 3, you want to see a big incision. You cannot do this for a 2 centimeter incision. Number 4, you want to see some bruising, some muscle aches if it was below the muscle. So it was, and number 5, the reputation of the patient and the doc, their relationship. Dr. Fang, and I'll use her name, I have huge regard for her. She believes in it wholeheartedly. She's the big voice for us to go out and say, you know what, this is a real problem. I entrust her from the way I've never met her, I have known of her, but from what the patients have said, she's earned that reputation along with Dr. Chan. I will say this, who is a wonderful man and an honest, sincere, you can see it in his eyes. You know he has built a reputation because you know what, when you go home, you're gonna write about this because the next patient is gonna say this is what you got. And if the third patient didn't see, then you come back and we'll talk and I'll explain as to what happened because there needs to be a check and balance on me,
Right.
on Dr. Chan, Dr. Fang, and all the other docs on that website because sometimes over time they say, oh, it's okay, I will leave the capsule behind. No. Sometimes, even in the best of the hands, it's a tedious dissection, but you have to do your darn best to remove it because you believe in it wholeheartedly.
Yeah, I've heard some women say that their surgeons are not gonna remove it because it's too thin. And again, this is predetermined before they've even
And
gone in
it'll
and
just
seen it.
absorb.
Yeah, they'll say it's so thin, it's just gonna absorb into the body, there's no sense on taking it out. And she actually went to two different surgeons, and this is what they said, and it's the complete opposite of
Yeah,
what
the capsule
proper
doesn't
protocol
reabsorb,
is.
by the way.
Yeah, capsule no, because I will tell you, as a physician, as a surgeon, look at my videos where I try to tear with all my might the silica, the hard capsule, and I showed this to you
Yeah.
yesterday. This will not get absorbed. This is just like saying if I put a concrete brick inside, that's going to get absorbed. Yeah, it probably take 10 million years.
No.
Because eventually all matter is solid. That it has molecules moving in it. But the bottom line is all of the capsule needs to go. And I will tell you in my training, and again, I've been fortunate enough to train at very nice institutions. The standard of care across the country, unfortunately, is to leave the capsule behind. And I will tell you that is from my experience as I've shown it. And I will show it to you right now. And I want you to go to my website. And this is, I am one of those who I want to see that I want proof. I want exactly evidence. And this is, as a biochemist in training, this is my patient. Breast implant capsule must be excised. This is the reason why. So the capsule was sent to the pathologist, and this is what I showed each one of you ladies. Refractive, polarizable material consistent with silica, which is implant capsule right breast. Consistent with silica. And if you Google silica, it is that small pocket or pamphlet that basically small your pouch that basically falls out of your jacket or your shoebox that basically absorbs. It's a foreign body and it should not be even eaten, and it says throw away. So, any other questions? Now what I want you to do is, Tracy, come back, hopefully more questions. Next time, what I want to do is, after I finish the seminar on June 18th, I had this very nice lady. You know what she told me afterwards? I'm upset at you. And she said, I thought you were going to call me because I want to explain my story.
Aw.
And this is the story where, and I use this as a word, as a story, because it is a sad story. This is the same lady I was talking about earlier when we were recording. Young, healthy female, super nice,
Like how young?
in her 20s.
Yeah.
Got implants inserted by an emergency room doctor who was
Oh.
going to have her implants removed for $700. Not making this up. She's going to see this herself.
This is in the US.
This is right here in town.
Oh, wow.
My gosh.
And I'm gonna let her, she's gonna be the voice, because I want you to come as representing someone who's representing Michigan. And I will tell you, you go through a lot, but I will tell you, this recording hopefully will help not only Michigan, but people all over the world, so that, you know what, we become the leaders, we become people who take this as a challenge and say, you know what, we're gonna make this world a better place. She,
He has to keep fluffing me back up. I get
no,
down.
because
I get all down and he's like, you're in this to
Yeah.
help the women. I'm like,
Yeah.
you're right.
Yeah.
Thank you.
she, if I'm not mistaken, 26. She had implants inserted by an emergency room doc who was going to remove them for $700 only.
Oh my God.
She's the same lady who had liposuction done by a gastroenterologist, GI doc, under local. Number 3, she's the same lady who had silicone injected into her buttock area, industrial grade. And I want her to
So that's
talk.
just loose?
Loose,
implant?
yeah, injected
And
100
you can't
times.
get it out, right?
You cannot. So guess what? And we will
100 times?
100 times, because you're injecting to build volume. And this is what you hear about in Florida or New York, that this was done by one of the pseudo, or what they call the non-plastic surgeons. Very illegal, by the way. Done right here in town. And I want her to share her story with you, so you come in, and so that we can explain, look at her. So I have a CT scan that I directed, and to show that she has a foreign body, and you can see the multiple injections. She wanted me, and I said I want proof that this is what it is, because I want to see evidence. I sent her to radiology, talked to the radiologist, who actually went in and did a ultrasound guided biopsy, sent it off, and it came back under the pathologist's read as foreign body, foreign giant cell reaction, consistent with silica, which is consistent with what the patient told me. So now we have hard evidence that this is silica. Now I'm left with the burden as to how to remove it, because it's scattered all over her back area. And not only that, she feels, this is the sad part, that there are worms crawling in her leg, because by gravity it's floating down. And I say this to you, unfortunately, this young lady, single mom, is going around town, and I'm sure there are many others that were victims of these other docs, who unfortunately are doing whatever they're doing, and everyone's looking the other way. And I'll tell you this, I'm going to be her voice, and you and I will make a difference in her life, hopefully, and hopefully in the lives of the other. And you would think something would be done about it, but you know what? I'm not scared to talk about it, because these are not going to be my words, these are her words, and I want her to talk so you can say, and we will talk to her so that I can explain, because I'm sure if it's happening in Michigan, it's happening in Ohio,
Oh, yeah.
it's happening
Everywhere.
elsewhere.
California for
Yeah,
sure.
yeah.
Oh,
And so that
most
we
definitely.
can teach the patients, you know, the administration has a purpose, has a role in this. The patients have a role to get educated. The surgeons have a role to talk about it. That's my part. And collectively, we want to make the consumer that you have to be very careful of this and these sets of what I would call dangerous doctors who are doing stuff which is 100% malpractice and illegal, period. So, you know, and again, all in an effort to make this world a better place.
amen.
So can I record your facility for everybody?
Sure, absolutely, absolutely.
Or
Go
do you want
ahead.
me to do it another day?
You know, you can do that.
Or do you want to send me some?
No, we'll send you some pictures. I know you took a
I
picture.
took a picture of the OR room and the recovery Actually, you were sitting in the waiting room, I was gonna take a picture, then you sat down. So, that's
So
yeah,
sorry.
I didn't know.
You know,
But
one
I didn't
thing-
know that I was gonna be sitting with you, otherwise I would've just told you that.
Now, one thing I want to
Move.
say, it is very important, and the society itself mandates that as a board certified surgeon, you cannot be operating in a room or a facility that's not accredited.
Right.
And it has to be accredited by the highest and the gold standard, internationally and within the US, which is what I was talking about, because it's not safe. I could give you badness, a germ, if I don't do it in the right
Mm-hmm.
environment, because it's very easy to introduce a bacteria that can multiply and cause an infection.
Yeah, I know people are like, oh, it's not in a hospital. I
Mhm.
think I'd rather be here because there's not as many germs.
Right,
The
yes,
hospital's
it's
all
true.
germs.
Yeah, and it's cleaned properly too, so, you
Yeah.
know.
I think I'd rather be in a suite.
Mhm.
Right. And you know, it is very much the standard of care across the world, by the way, because this is the same group that attests not only within the US, this is the highest standard. They come in, they look at the autoclave, they make sure, they review all the charts. This is their reputation online. If they don't, if they see how many complications, you know, patients with a pacemaker, they're not coming here. Patients who are sick COPD, who don't get the cardiac clearance, not coming here. I don't like surprises.
Right.
That's why I go right across like 300 steps that way at a major hospital, and I do it at the major hospital. I don't like surprises, and this is why the whole workup needs to be. You know, so that when we go in, we have a defined mission in the operating room, take care of the situation, and come right out of Dodge in a very timely fashion. Surgery is very involved. I will tell you from my experience as a board certified surgeon, surgery is very easy. In order to prepare the patient for surgery, to know, just like in your case, the Lovenox, remember I talked to you on the weekend and before, you know, and to say what was it when you had the other surgery done and how did it done, and I would rather do it, I would take the chance,
Right.
because I don't want you to get another clot, God forbid, because I want to do it, yes, I will. And I only did 2 that day because I was ready to do 5 or 6 hours for you.
Right.
Yeah, because normally I do 3 in a day. So the bottom line is, every patient is different, and every patient is a challenge, so that it's done right and it's done very thoughtfully and systematically.
Okay, do you have 5 minutes to get your suite on there?
Sure, absolutely.